If you're over 60, what I'm about to share may surprise you, maybe even shock you. For decades, seniors have walked into doctors' offices expecting compassion, fairness, and clear answers, only to discover, sometimes painfully, that the system doesn't always see them as individuals. After speaking with hundreds of healthcare workers, listening to retired physicians, and reading the data, I've uncovered 5 disturbing truths about how doctors really think of older adults. And let me tell you, these aren't just abstract ideas. These hidden biases are quietly shaping your care, affecting your diagnoses, and in some cases, stealing years from your life. Here's the reality. There's a form of prejudice in medicine that doesn't make headlines but affects millions every single day: ageism. It's the silent force behind rushed appointments, brushed-off symptoms, and treatments that somehow always feel less than. One retired physician even called it the healthcare industry's worst-kept secret. But here's the good news. Once you understand these hidden truths, you can flip the script. You can walk into every appointment prepared, confident, and equipped with strategies that command respect. That's what this conversation is about. Today, we're exposing 5 ugly truths about medical ageism, truths the system hopes you'll never notice. And more importantly, I'll give you the exact tools successful seniors use to transform their medical care. If you've ever felt dismissed, rushed, or underestimated, this may be one of the most important lessons you'll hear this year. Now, let's dive into the first ugly truth and how you can protect yourself starting at your very next appointment. Imagine walking into a medical office, sitting down, and before you've said a single word, the doctor has already drawn conclusions about you. Sounds unfair, doesn't it? Yet this is exactly what happens to countless seniors every day. The moment your age is visible on the chart, or simply visible on your face, a mental shortcut kicks in. Doctors often label older patients as complicated, resource-heavy, and time-consuming before the conversation even begins. Dr. Sarah Henderson, a former emergency room physician who now fights for senior rights, explained this in plain terms. Medical schools actually train doctors to use efficiency protocols, and those protocols lump seniors into the high-maintenance category. The logic is simple. Older patients usually take more time, need more tests, and juggle more medications. But here's the problem: once that assumption is made, it colors every decision in the room. And let's not forget the financial pressure. Insurance reimbursements have been declining for years, while patient quotas keep rising. So what happens? A doctor under stress looks at a 68-year-old or a 74-year-old and silently calculates. This appointment will take too long. This will cost too much. I need to keep things moving. And whether they realize it or not, that resentment seeps into how they treat you. Consider Maxine, a 74-year-old retired librarian. She walked into her appointment with a carefully written list of symptoms she'd been tracking for weeks. Before she could finish her first sentence, the doctor cut her off. "Let's focus on your main concern today," he said, with a sigh. When she tried to explain how all her symptoms connected, he brushed aside her chest pain as probably anxiety. 6 months later, Maxine was finally diagnosed with a heart condition that could have been caught earlier if her doctor had simply listened. 6 months lost because her age made her seem too complicated. Sadly, Maxine's case isn't unique. Studies show that doctors spend about 23% less time listening to patients over 65 compared to younger patients with the exact same symptoms. Think about that: nearly a quarter less time, just because of age. And the effect isn't just shorter conversations. It leads to missed diagnoses, weaker treatment plans, and patients walking away feeling invisible. But here's the truth. You don't have to accept this bias. There are proven ways to reshape how doctors see you right from the start. First, begin every appointment by stating your measurable health goals. Instead of saying, "I feel tired," you could say, "My energy levels have dropped about 40% over the last 3 months, and I want to identify the reason." That small shift reframes you in the doctor's mind. You're no longer a complex senior. You're a goal-oriented patient. Second, bring a concise one-page health summary. Highlight not only your medical history, but also improvements you've achieved from past treatments. Show that you're active in your own care, not just waiting for instructions. Doctors naturally respond better when they see you as a partner instead of a problem. Third, respect their time but protect your needs. Say, "Doctor, I understand today's visit is short. Could we schedule a longer appointment next week to fully review my cardiovascular concerns?" That simple sentence communicates respect while making clear that your issues deserve full attention. And finally, take notes. When a doctor sees you writing things down, something shifts. They realize their words matter. They know you'll remember. And that accountability improves how they listen and how they speak to you. So the next time you step into a medical office, remember this. Your age may trigger assumptions, but your preparation can rewrite the story. Don't let yourself be labeled before you even open your mouth. You have the power to shape that interaction. Now let's move to the second ugly truth, and this one might sting a little. Too often, when seniors describe troubling symptoms, doctors brush them aside as nothing more than just getting older. There's a term for this, it's called medical gaslighting. It means dismissing real problems by blaming them on aging instead of investigating what's really going on. Dr. Michael Torres, a geriatric specialist who has spent his career fighting age bias, said it best. The phrase, "you're getting older," has become a medical cop-out. Instead of asking, "What's causing this?" doctors jump to, "That's expected at your age." But here's the danger: symptoms that would trigger urgent tests in a 40-year-old are ignored in a 70-year-old. The statistics are alarming. Research from the American Geriatric Society shows that 85% of serious conditions in seniors are first dismissed as normal aging before the proper diagnosis is made. Heart disease? Labeled as fatigue. Thyroid problems? Written off as low energy. Depression? Brushed aside as adjusting to retirement. Even early cancer signs are too often ignored as simple wear and tear. Think about Carl, a 67-year-old former construction supervisor. For 8 months, he complained of worsening joint stiffness and exhaustion. Every visit ended with the same line, "Carl, you're not 30 anymore. This is just what happens." But when Carl finally insisted on blood work, the truth came out: he had severe rheumatoid arthritis, and by then permanent joint damage had already set in. 8 months lost, all because his doctor saw age instead of illness. And it's not just joints or fatigue. Women, for example, face double discrimination. Their symptoms are dismissed as both aging and hormonal changes. Men often have sexual health or emotional concerns brushed off as normal male aging. The result? Missed diagnoses, delayed treatments, and unnecessary suffering. The real tragedy is psychological. When authority figures keep telling you that your symptoms are normal, you start doubting yourself. You wonder, maybe I'm overreacting. Maybe this is just aging. That self-doubt delays care even further. It creates a cycle where seniors suffer in silence until conditions become severe. So, how do you fight this? The answer is clarity and data. If a doctor says, "That's normal for your age," respond with a calm but firm question. What percentage of people my age experience this exact symptom? In most cases, they can't answer because they're making assumptions, not relying on facts. Next, create a timeline. Instead of saying, "I'm more tired lately," present it like this. My energy levels were steady until March 15th. Since then, I've needed daily naps for the first time in my life. That detail changes everything. It reframes the issue from old age to sudden change, and sudden changes deserve investigation. Another powerful tool? Ask, "What tests would you order if I were 40 with these same symptoms?" That question forces the doctor to confront their own bias. It makes them justify why they'd treat you differently based on age alone. And don't be afraid to escalate your concerns. Try saying, "Doctor, I know aging affects energy levels, but this is a sharp change from my normal baseline. I want to rule out medical causes before assuming it's just aging." That phrasing shows you're informed, reasonable, and serious. One more strategy: bring an advocate. Whether it's a spouse, a child, or a trusted friend. Another set of ears changes the power dynamic. Doctors are less likely to dismiss you when someone else is listening, taking notes, and asking questions. The bottom line? Gaslighting thrives in silence. When you come armed with facts, timelines, and specific questions, you disrupt the pattern. You stop being seen as just aging, and instead, you become a patient whose symptoms demand real attention. So the next time you hear, "That's just part of getting older," don't let it slide. Challenge it. Because your health deserves answers, not excuses. The third ugly truth may be the most insulting of all. Many doctors secretly assume that once you pass a certain age, your mind just can't keep up. They believe you won't understand complex treatments, that you won't be able to follow detailed plans, or that you simply don't have the mental sharpness to make sophisticated medical decisions. And this assumption quietly shapes the care you receive. Dr. Amanda Richardson, a neuropsychologist who studies medical bias, has shown through her research that healthcare providers consistently underestimate the intelligence and memory of patients over 65. They automatically simplify explanations, avoid advanced therapies, and default to easier treatment paths, not because of evidence, but because of stereotypes. The consequences are devastating. When doctors assume you can't handle complex care, they don't even tell you about it. That means no discussion of advanced surgeries, no mention of cutting-edge drug therapies, and fewer opportunities to join clinical trials. You're quietly pushed toward simpler, often less effective options. Just look at Louise, a 71-year-old retired chemistry professor. When she was diagnosed with early-stage breast cancer, her oncologist immediately recommended a simple mastectomy. No discussion of reconstruction, no mention of targeted therapies, no clinical trial information. When she asked why, he said, "At your age, we want to keep things straightforward." Louise had to fight for months just to be offered the same treatment choices automatically given to younger women. And this isn't just about cancer. It shows up in everyday interactions. Doctors talk slower, use childlike vocabulary, and skip technical details, even when the patient clearly has the background to understand. They prescribe once-a-day medications that may be less effective than multi-dose regimens, simply because they assume seniors can't manage a more complex schedule. They hesitate to recommend health apps, digital monitoring tools, or online portals assuming seniors won't know how to use them. The result? Seniors are cut off from modern medicine not because of ability, but because of prejudice. And worst of all, repeated experiences like this can become a self-fulfilling prophecy. When you're treated as if you can't handle information, you might start believing it yourself. Some older adults stop asking detailed questions, stop researching their conditions, and start depending entirely on others, even when they're fully capable of managing their care. But here's how you break that cycle. Start every appointment by establishing credibility. You might say, "I managed complex projects for 30 years, so please give me the detailed information I need to make the right decision." That one sentence signals to your doctor that you expect depth, not shortcuts. Don't shy away from medical language. For example, instead of asking, "How will this pill help?" try, "Can you explain how this medication addresses the underlying cause of my condition?" When you use precise words, doctors recognize that you can handle precise answers. Bring evidence of your engagement articles you've read, questions you've prepared, even notes from other specialists. This shows you're informed and committed, and it forces providers to move past assumptions. If you suspect you're being given oversimplified options, ask directly, "What additional therapies would you recommend if I were 45 with the same condition?" That question cuts through the bias and makes them justify their choices. And here's a tip many seniors overlook: use technology right there in the exam room. Open your health app, review your digital records, or look up a medication interaction on your smartphone. The moment your doctor sees you using these tools, their assumption that seniors can't do tech crumbles. Finally, request detailed written treatment plans. Say, "I'd like a full outline of my options so I can review them in depth." This makes it clear you want and expect to be fully informed. The truth is, your brain is not defined by your birth year. Many seniors stay sharp, curious, and capable well into their 80s and beyond. You deserve to be treated as an individual, not a stereotype. By showing confidence, using precise language, and demanding details, you can dismantle the myth of cognitive decline in the doctor's office. Because your mind is one of your greatest assets, and it should be respected that way. Now we come to the fourth ugly truth, and this one can be both heartbreaking and dangerous. Too often, medications are prescribed to older adults not for true medical treatment, but as a way of managing behavior. In other words, the drugs aren't always about healing, they're about control. Dr. James Martinez, a former nursing home medical director who later became a patient advocate, has gone on record about this disturbing practice. He explained that sedatives, mood stabilizers, and psychiatric drugs are often handed out to seniors not because they're clinically necessary, but because they make patients easier to manage. Anxious? Here's a sedative. Asking too many questions? Here's an antidepressant. Assertive or frustrated? Here's a mood stabilizer. It's chemical restraint dressed up as medical care. The statistics back this up. More than 40% of seniors are prescribed at least one psychiatric medication, but only about 12% actually have a diagnosed mental health condition requiring that drug. That gap is enormous, and it tells us something troubling. Most of those prescriptions are for convenience, not necessity. Take Beverly, a 69-year-old former school principal. After hip surgery, she became frustrated with her slow recovery and started asking detailed questions about her rehab. Instead of supporting her curiosity, the care team labeled her difficult and prescribed anxiety medication. The drug caused confusion and balance issues, and she ended up falling and breaking her wrist. Instead of helping, the medication added 4 more painful months to her recovery. And it doesn't stop there. Seniors are often prescribed sleep aids for normal, age-related changes in sleep, not true disorders. Pain medication may be withheld because providers assume seniors are exaggerating or drug-seeking. Blood pressure medications are sometimes given at dosages that cause dizziness, leading to falls. When seniors complain, the side effects are brushed off as necessary trade-offs. Even worse, these drugs can create the very problems they're supposed to solve. Sedatives may trigger confusion that gets labeled as dementia. Mood stabilizers can cause apathy, later mistaken for depression. Sleep aids can disrupt natural sleep cycles, ironically creating long-term sleep disorders that require even more pills. It's a vicious loop. So what can you do to protect yourself? First, insist on clarity. Before you accept any prescription, ask, what specific medical condition is this treating? How will we measure its success? And when will we know it's time to stop? If your doctor can't give clear answers, that's a red flag. Second, research independently. Reliable medical websites can help you understand what a drug is truly for, what side effects to expect, and what alternatives exist. Sometimes, the behavior prompting a prescription can be addressed by adjusting the environment, managing pain properly, or using therapy without adding more chemicals to your body. Third, demand measurable goals. Say, if I don't see clear improvements in 4 weeks, I want to review this prescription. This keeps you from being locked into unnecessary medications indefinitely. Fourth, request regular medication reviews with a pharmacist or geriatric specialist. These professionals are trained to spot dangerous combinations, unnecessary drugs, and safer alternatives. Many seniors are shocked to discover they're taking medications that serve no therapeutic purpose at all. Finally, document your baseline. Take notes on your memory, balance, and mood before starting any new psychiatric medication. That way, if side effects appear, you have proof. And always choose a trusted advocate, a spouse, a family member, or a close friend who can step in if medications ever affect your judgment. Because the truth is this: medications should be tools for healing, not shackles that keep you quiet. You deserve treatment that respects your mind, your independence, and your dignity. And every time you question unnecessary prescriptions, you not only protect yourself, you challenge a system that too often values convenience over care. The fifth ugly truth is perhaps the most chilling. Behind closed doors, many doctors are trained to weigh your treatment options, not just by your condition, but by something called life value. In practice, that means your age is silently used to decide whether the system thinks you're worth the cost of aggressive treatment. Dr. Patricia Chen, an ethics professor who studies healthcare rationing, explains it like this: medical training often includes concepts such as quality-adjusted life years. These formulas assign numerical values to remaining years of life. A 70-year-old automatically gets scored as less valuable than a 40-year-old. And those calculations ripple through the system from organ transplant lists to cancer treatments, from surgery approvals to diagnostic scans. The impact is devastating. Seniors are denied procedures not because the treatment wouldn't work, but because the system deems it not cost-effective. Imagine needing a heart valve replacement and being told it's too risky for your age, even when your health profile is strong, or being steered into palliative care instead of dialysis. Not because you wouldn't benefit, but because the years you could gain are considered less important. Walter, a 68-year-old retired engineer, experienced this firsthand. Diagnosed with kidney failure, he was immediately told dialysis might not be appropriate at his age. In reality, his overall health was strong. Walter fought hard for 3 months to get the same treatment younger patients received without question. And when he finally did, he went on to live 7 more active years. 7 years that would have been stolen if he had accepted that first age-based decision. The discrimination doesn't stop with major procedures. Preventive screenings, advanced imaging, and even mental health services are often withheld from older patients under the assumption that they won't live long enough to benefit. Depression in seniors is brushed off as natural aging instead of being treated with therapy. Emergency room doctors admit that older patients receive fewer tests and shorter exam times compared to younger people with identical symptoms. Even families are influenced. Doctors may frame decisions in terms of comfort care or age-appropriate limitations, gently steering loved ones to accept less aggressive treatment. What they don't always admit is that economics, not medicine, is driving those recommendations. So how do you fight back? You start by asking the right question. Would you recommend this same treatment if I were 45? If the answer is no, demand an explanation based on medical reasoning, not cost or age. Second, research treatment outcomes for people in your age group. You'll often find that seniors respond just as well as younger patients when given equal access. Bring that evidence into your appointments. Third, seek multiple opinions. Geriatric specialists, in particular, understand that older adults can thrive with the right care. What one doctor calls too aggressive, another may call exactly what you need. Fourth, document every instance where age seems to influence decisions. Senior advocacy organizations and even legal experts can step in when necessary. Remember, age discrimination in healthcare is not only unethical, it's unlawful. The bottom line is this: your life has equal value. You deserve treatment based on your health, not on a spreadsheet calculation of your years left. And when you advocate for yourself, you're not just protecting your own future, you're reshaping how the system treats every senior who comes after you. Now you've seen the 5 ugly truths about medical ageism, truths the healthcare system hoped you'd never discover. Doctors labeling you as complicated before you speak. Symptoms dismissed as just aging. Treatments simplified because they assume you can't understand. Medications used for control instead of healing. And finally, the cruel economics that devalue your life based on age. But knowledge is power, and you are no longer in the dark. You now have tools to challenge assumptions, demand equal care, and step into each appointment with confidence. Remember Maxine, whose heart condition was missed until she insisted on clarity. Carl, who pushed for blood work and finally got a diagnosis. Louise, who fought for advanced cancer treatment. Beverly, who exposed the misuse of medication. And Walter, who gained 7 more years by refusing to accept too old as an answer. These aren't rare exceptions. They are proof that when seniors advocate for themselves, outcomes change. And when outcomes change, the entire system begins to shift. Every time you demand respect, request evidence, or insist on thorough care, you're not just protecting yourself, you're opening doors for every senior who follows. So as you walk into your next appointment, carry this with you. Your age is not a weakness. It is wisdom. Your health is not negotiable. It is valuable. And your life deserves the same dignity and quality care as anyone else's, no matter the number of candles on your birthday cake. If this message resonates with you, share it with a friend, a spouse, or a neighbor who needs to hear it. Leave a comment below if you've ever felt dismissed because of your age. Your story might be the encouragement someone else needs. And if you want more conversations like this, consider subscribing so you never miss the strategies that keep your later years strong, independent, and respected. Together, we can push back against the system. Together, we can demand the dignity we deserve. And together, we can ensure that growing older never means being treated as less.